Good afternoon and hello, everybody. Welcome to this edition of our Million Hearts Learning Lab, leveraging pharmacists to get better blood pressure control, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in our clinical affairs division here at NAC, and I'm pleased to bring this event along with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. First things first, this event is being recorded for playback at a later date. Automatically joining this event consent you to this recording. All attendee lines have been muted or essentially been disabled, so you should not be able to unmute your line if you're an attendee today. Your video has also been disabled as well. The duration of this event is going to be approximately 45 minutes, including a very brief presentation and, of course, Q&A. And let's get to the Q&A. Thank you for folks that have submitted questions in advance. We greatly appreciate that. But if you have questions throughout today's session, please use the Q&A box. It's either at the top of your Zoom screen, maybe at the bottom of your Zoom screen. Sometimes you need to take your cursor and hover to wake that up. Simply type your comments, questions, or concerns into this box at any time. We will answer as many questions in the time allotted with the additional resources. At this moment, I'd like to turn things over to Judy from the CDC, who's going to be taking it from here. Judy, the floor is yours.
Great. Thank you, Elizabeth, and welcome everybody to the May Learning Lab. Today's session will be about improving hypertension control with a specific role, what pharmacists, the key roles that they have in getting to the Million Hearts goal of improving 20% hypertension control, while addressing the needs of people with lower incomes and people from minority groups. I am absolutely confident you will have a couple of takeaways from today's meeting that we hope you can deploy in your own area, and get your questions ready, because we do have plenty of time for questions and answers. With that, let me turn it over to Meg.
Thank you, Judy. I'm Meg Metter with the NAC team, and I just want to do a quick review of how our Million Hearts Learning Labs are structured. So as Liz mentioned, the total time for the Learning Lab live session is 45 minutes, but the actual time for our whole package is 60 minutes. So the same as a traditional webinar, but broken into 3 pieces. The first is a pre-work video recording, and that's followed by a pre-work survey to gather your questions, and then today's live event. So our live event is 45 minutes. We'll be sharing at the end of this event how you can apply for CME credits. Next slide. We have 3 learning objectives for today. The first is specify examples of how pharmacists add value to hypertension treatment. We also want to share resources for pharmacists, expanded care team members, and public health professionals about how to engage pharmacists in hypertension treatment and management. And then the third objective is to increase your understanding of the range of options to leverage pharmacists' expertise. So very exciting content, very cutting edge. We have 2 excellent speakers here today to answer your questions. So excited to have them. Thank you. So we have Dr. Adair Bleiler, and she's with the Smith Heart Institute Hypertension Center with Cedars-Sinai Medical Center in Los Angeles, California. Joining her is Dr. Nicole Therian with the Division for Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention in Atlanta. So thank you so much to you both for being here. We're actually going to kick this off with a short presentation, as Liz said, that's going to be delivered by Nicole. So thank you so much.
Thank you, Meg. And just a reminder that the findings and conclusions in this presentation are those of the presenters and do not necessarily represent the official position of the CDC. Next slide, please. Collaborative drug therapy management is the partnership between qualified pharmacists and prescribing clinicians to manage a patient's drug therapy as defined within the context of a collaborative practice agreement. This approach allows pharmacists to deliver services such as selecting, initiating, adjusting, and monitoring medications, ordering and interpreting laboratory tests, and administering drugs. Next slide, please. Collaborative practice agreements create a formal practice relationship between a pharmacist and a prescribing clinician, most often a physician, though some states do allow CPAs between pharmacists and other health professionals, such as physician assistants and nurse practitioners. The agreement specifies what functions, in addition to the pharmacist's scope of practice, can be delegated to the pharmacist by the collaborating clinician. The terms and functions provided under a CPA vary from state to state based on the pharmacist and the prescribing clinician's scope of practice and the state's collaborative practice laws. Next slide, please. Currently, 49 states and DC have laws in effect that allow prescribing clinicians to delegate authority to pharmacists to manage patients' drug therapy. Delaware is the only state that does not currently have such law. CPAs can have many components, which include the scope of the agreement, covering things such as patient inclusion criteria, authorized patient care functions, legal components, including authority and purpose, liability, informed consent, the duration of the agreement validity and review process, and administrative components such as training and education, documentation, communication, and quality assurance or quality measures. Next slide, please. State laws and regulations vary widely. As I mentioned, most states have laws regarding collaborative practice agreements, but there are variations. Some of these variables include authorized functions of the collaborating pharmacist or pharmacists, including which services, such as modifying, initiating, or discontinuing medications, may be performed. They may also include variables such as the participants in the CPA, including the number of pharmacists and collaborating prescribing clinicians, pharmacist to clinician ratio, the number of patients, the types of prescribing clinicians, and the relationship between the clinician and the patient. And finally, they may also include requirements or restrictions, including continuing education, qualifications of the pharmacist, liability insurance, disease states or conditions to be managed by the pharmacist under the CPA, medications to be managed, involvement of the patient. This can mean that does the patient have to opt in or opt out, and how do they do this? Additionally, this can include documentation, notification, and communication between the pharmacist and the prescribing clinician. And finally, it can include duration of the agreement validity. Before entering into a CPA, pharmacists and prescribing clinicians may benefit from reviewing their state's current laws and regulations pertaining to CPAs. State boards of pharmacy and medicine and state pharmacy and medical associations can serve as point of contacts for the most up-to-date information on CPA authority in specific states. Next slide, please. CPAs focused on caring for patients with chronic disease, including CVD, can empower pharmacists and collaborating prescribing clinicians. For more information, can be found in this resource, which I think we'll include the link to later, that highlights much of the information I just mentioned, as well as additional information. Next slide, please.
Thank you so much, Nicole. I mean, really powerful information. Yes, we will definitely include a link to that resource at the end. I wanted to say we got a number of great questions that really helped us shape this session today to tailor that to the things that you're most interested in hearing about. But we still want to hear from you today. So if you didn't have a chance to answer questions on the pre-survey, you still can. So feel free to add those in. We'll do our best to try to get to at least a few of those. But I wanted to start with a theme that we had. We had a number of questions that came in on engaging pharmacists. The good news is that many of you are not only familiar with the concept of the pharmacist being part of the healthcare team, but really actually very excited about engaging one for hypertension care, which is great. You had lots of questions about how to engage pharmacists, particularly if they were not part of your organization. So we want you to feel like this webinar is for you, even if you maybe don't have a pharmacist that's part of your care team. If you're just looking into the idea, the concept, how does that work? So the first question I have is actually for both Nicole and Adair. Nicole, why don't we start with you and then we'll go to Adair. What are some tips that you would share on how best to engage pharmacists?
Thank you, Meg. This is a great question. I would say an important early step is to convene a group of team members and decision makers. And this might include pharmacists, clinicians, and leadership. to discuss priorities and jointly determine goals, objectives, activities, and expectations of each partner. Partnerships and engagement can look really different. And so it's really important during these early conversations to figure out what is going to work best for this specific program or initiative, including having conversations early about communication, including the format and frequency, as well as evaluation or outcome reporting.
Thank you, Nicole. Adair, same question to you. What are some tips you would share on how best to engage pharmacists?
Yeah, so I think what I would say first is, so pharmacy career pathways are diverse, meaning, pharmacists have varied interests, experiences, skill sets. And I say that because it's probably important to know that not every pharmacist that you may approach may have the desire to provide clinical services. As for how to best engage pharmacists, I'm not sure there's like a right or a wrong way. As Nicole sort of alluded to there, I recommend you have sort of a very clear vision for how that pharmacist will complement your existing clinical practice so that you could make that pitch to them. I think particularly if you're entering into a community or retail pharmacy environment where the demands on the pharmacist's time are quite high, it's important to have a sort of well-defined ask of them so they can make an informed decision about whether or not it's something they could realistically take on. But, I love that we're even talking about engaging pharmacists, because I think more often than not, pharmacists are continually having to make the case for why they should be included on healthcare teams and how they can have a positive impact on patient outcomes. And I just think it's really exciting that we're now moving into the space where healthcare leadership and clinicians really recognize the value of pharmacists and are interested in exploring partnerships.
Super. Adair, you said something that I think resonates with a lot of, at least the health center audience on the call today. So a lot of health centers don't have a pharmacist on their care team. That's not a luxury that they have, but they often are in partnership with a community pharmacy or retail pharmacy. So they have maybe a contractual relationship. And you mentioned sort of that can be a little tricky because sometimes they're really busy and have to do a lot of other functions. But still, I think the question therein lies is, how do you engage those pharmacists who are not embedded in your health system? I'm actually going to ask this of Nicole because you gave a great answer already, Adair.
Yes, this is a great question, and that was really tied in very well. I would highlight again to bring together a group to jointly build the program or partnership. I'd also highlight that it's important to explore the landscape of community pharmacies in your specific community. There is some variation in the type of community pharmacies, including those that are independently owned or part of a small regional chain, or those that are part of larger chains, including those located in superstores or grocery stores or a standalone pharmacy. Navigating the organizational structure and engaging decision makers, as well as what services are offered, may look different across these different types of pharmacies. Consider exploring what types of pharmacies are most common in your community, because this can have some really large variation regionally and also within cities. And consider exploring what pharmacies your patients are currently using to see where there may already be touch points or interactions. I would say in terms of services that could pharmacists outside of your organization may be able to provide, there really is a range of services that pharmacists can provide in settings that aren't co-located. This can include everything from support for SMBP or out-of-office blood pressure measurement, assessment and tailored services to support something specifically like medication adherence, medication therapy management, or collaborative drug therapy management. There are sometimes challenges to implement collaborative drug therapy management outside of co-located collaboration, but it can happen in many states. So finally, I would really just highlight collaboratively building that program can ensure that the program fits the needs, priorities, and the resources of both organizations to ensure a successful program.
Thank you, Nicole. And I actually want to pivot for just a moment. We have a couple of questions that came in through the Q&A. A few of them are billing related, and we're going to touch on that topic a little bit later. But one of them, I think Nicole, you could probably answer this. You were talking about, which states have the ability for people to use a collaborative practice agreement. The question is, do you have a recommendation on where to find a summary of the scope of practice for all 50 states? And maybe that's something we can share.
Yeah, that's a great question. I will say this is sort of a constantly evolving landscape as new legislation is being introduced and implemented in states. So we currently don't have a resource available for scope of practice for pharmacists. It's something we are exploring, and there may be a resource in either later this year or next year. But I would encourage looking at state-specific information because it can change across states during those legislative sessions or even as rulemaking and implementation of already enacted policy is occurring.
Super, thank you. And Dara, I'm going to ask this question to you, and you may not have an answer for it. And so feel free to say that you don't have an answer for this particular one. But the question is about, a community pharmacist that has a collaborative practice agreement set up with a healthcare delivery organization. And then it says, if that results in prescribing or prescription being filled at that pharmacy, is that sort of a strange kickback scenario? I don't think it is. But I just, it's a question that's posed, and maybe we don't have a good answer for it.
Yeah, I don't know that I have a great answer. I know it happens. I know that those sort of relationships are being developed between individual practices and community pharmacies. I would assume that if the patients that are being managed are already have an existing relationship with that pharmacy, then it's an okay thing. And at least as I know, for some of these sort of larger MTMs, like outcomes MTMs, platforms that people use to do MTM, a lot of times they're able to select patients out of that platform and manage them. And sometimes that comes with them becoming a new customer. And there's no conflict of interest with that. So I think it's fair game, but don't quote me on that.
So I would have, as a non-pharmacist, I would have guessed the same thing, because a lot of organizations actually have an in-house pharmacy. And so it's sort of the same setup. But let's move on. There's another question in the Q&A about buy-in, and we have some great sort of questions that were posed in the pre-survey about that topic. So let's move on to engaging providers and clinicians and also talking about buy-in. So this is a theme, as I said, that came up a lot. And I want to sort of ask you, how can pharmacists build relationships and trust to get that provider clinician buy-in so they can work effectively as a team member? And Nicole, maybe let's start with you, and then we'll move to Adair.
Yes, I think this is a really common question. I would say clearly defining goals, objectives, and activities, and then how those things will be evaluated can really support a successful and trusting relationship, I think, for all involved, when there's as much transparency and clarity about expectations, and then how those expectations or how the program will be measured and how adaptations may happen is really important for both sides to make sure that they're happy with the program. I'll say that many successful team-based care models involving pharmacists describe their guiding goal as a shared goal, a shared vision across all partners to be providing the best possible care to patients, and especially in non-co-located or interventions that occur outside of more traditional clinical settings. Part of that may be to provide increased convenience for the patients. I would also say another key facilitator can be the agreement on preferred method and frequency of communication between the pharmacist and the collaborating clinician. There's really wide variation in individual preferences. And that may change throughout the life of the partnership. There may be a preference for more frequent communication really early on as the partnership is new, and that may change over time. So discussing these and being transparent is really important, that to make sure that those are understood and agreed upon early on.
Thanks, Nicole. Adair, to you.
Yeah, I think this is tough. As I alluded to before, this is typically the situation that pharmacists find themselves in. So they're having to demonstrate their abilities, demonstrate their worth. I think education is a big piece of this. I don't think like society at large is sort of like really readily aware of what training is required for pharmacists. So, new PharmD programs require a minimum of 4 years. That's just like medical school. And many pharmacists now are going on to do 1 and 2 years of residency, depending on their interest in specializing. So, that's anywhere from 4 to 6 years of sort of like laser focused education on medications. And in addition to that, there are a number of certificate training programs and board certifications that are now available to pharmacists. And I think at sort of a base level, this is an easy way to not only communicate your skill set, but also allay any concerns that might still exist among clinicians about pharmacist readiness to provide clinical services. As it relates to sort of building relationships, I think it's a little bit hard to speak in generalities. It really sort of depends on the environment the pharmacist finds themselves in. So a pharmacist in a retail or community setting would have a very different challenge compared to someone who's already, embedded in a clinic or is hospital-based. I think what I've done personally is always tried to clearly delineate for clinicians what my role is and what my goals are, and also what they are not. Unfortunately, we do like sort of exist in this time where there's like sort of turf wars between like different levels of providers. And I always sort of feel inclined to state, I'm not here to steal your patients. I'm here as an extension of you and your practice to help improve the care that you provide to patients. I think ideally, when you're first setting out to sort of create these relationships or partnerships, you want to target organizations or specific clinicians that have a history of working with pharmacists. And then, as Nicole said, you really want to make it a collaborative effort. I always ask lots of questions about how can I be a help to you? Like I want to be a help, not a hindrance. And then really make it a collaborative effort. When you work together to create care pathways that play to everyone's strength, there's sort of this automatic buy-in that happens because everyone has a seat at the table and sort of a say in how things go.
Really appreciate that. It's true, Adair, it is new territory for a lot of clinicians, but I think it's interesting in our Million Hearts project with NAC, some of the health centers that are going down this road and exploring these collaborations have had their clinicians really experience how much pharmacists can help give them more time with new patients and give them more time with complex patients. And it actually expands their ability to see more patients or increase their panel. Absolutely. So it's not about actually taking patients away from the clinicians. It actually increases their opportunities, probably with those that need the clinician care most. So I just wanted to share that sort of bit that came out of our own project, really attesting to what you said. So I want to ask a follow-on question that gets at buy-in, but from a different perspective. So we talked a little bit about sort of clinician buy-in in terms of pharmacist engagement. What about patients? How are patients accepting pharmacists from your point of view? Have you experienced any challenges, or are there strategies that can kind of help patients to see the pharmacist as a key player in their care team? Nicole, you want to start with this one, and then we'll move to Adair?
Yes, I can. I think that one of the most valuable things can be a warm handoff and again, transparency of the role when a patient is going to be working with a pharmacist, for that to feel like an extension and part of the care team rather than a separate area. I also see, I'm going to go a little bit on one of the questions about identifying patients that I see in the Q&A. And I think that there have been some programs that have identified and at the time of identification told the patient, we're going to refer you using flags in electronic health records. For example, if a patient has an elevated blood pressure, they might be referred to the pharmacist for collaborative drug therapy management of hypertension. And at the time when they're in front of a clinician or another healthcare team member, they're told about, we're going to have you work with a pharmacist who will do these things for this goal.
Adair, to you, patient.
Yeah.
Advice
Sorry,
about patient engagement.
Yeah, so I think there's this is something that's still a challenge. So it's great to hear like the progress you've made at NAC, and that you've got providers and the healthcare leadership sort of coming around to the idea that pharmacists can have a really beneficial impact on the care team. I still think that pharmacists providing patient care is a relatively new concept to many patients. I hear a lot, I work with a lot of pharmacists and trying to implement research programs, and something that they are always telling me that they hear is that patients say to them, well, I just don't want you to do anything or change anything without you talking to my doctors first. And I get that it's still sort of a relatively new concept, especially when it's a community pharmacist trying to implement some sort of change to a medication regimen, for example. As we just talked about, clinician buy-in is really, it's essential. And as Nicole said, a warm handoff is really the best strategy, I think, that we have to getting patients to engage with their pharmacist. I'll use my own practice as an example. So I work in a hypertension specialty practice that's part of the Division of Cardiology at Cedars-Sinai. I work closely with one cardiologist in particular, and I attend every new patient appointment with him. So when they meet him for the first time, they also meet me for the first time. And, it's wonderful. We've got like sort of a rhythm, the two of us. When we walk in, he always says, hi, I'm Dr. Rotter. This is Dr. Blyler, a pharmacist. And together we're going to tackle your hypertension. And I think that single line not only legitimizes my role in the eye of the patient, but it also makes clear to them that I'm going to be sort of an active participant in their care going forward. So after that first appointment, when they have questions about medication coverage or side effects or interactions or how their blood pressure is maybe responding to the treatment we've prescribed, and they send messages to us through our little provider portal, they're not caught off guard when I respond instead of Dr. Rotter, because they know who I am and they know that I'm familiar with their case. We also make clear from the get-go that I'm going to be the one who's going to assist with med titration sort of in between the in-person clinic visits. So again, I'll respond to home blood pressure readings that get sent in and make adjustments to medications or doses as I see fit. And with this strategy, we virtually get no pushback from patients. A lot of the patients that I've had to call to communicate medication changes, now they have my phone number, they communicate directly with me. And I recognize that this is not a situation that all pharmacists find themselves in. I think, again, particularly when you're not clinic-based, this can be a challenge, but the clinician can support engagement with the pharmacist by explaining why it's important, why the meeting with the pharmacist is important. And I just think that endorsement is really what's key.
I think this is so, it's just a testament to how powerful sort of the recommendation from the clinician is in all sorts of ways. And I think whether it's a warm handoff or whether you sort of endorse it in real time, the pharmacist as part of your care team, I just think that does make all the difference. So the clinician buy-in seems to come first, maybe, and then having that clinician really speak on behalf of and the capabilities of the pharmacist as part of the care team. So I want to transition to another topic that surfaced as really important, and we can also see a lot of questions that have come in on this topic as well, around billing. So quite a few of you have these questions relating to billing or reimbursement for pharmacist services. Want to just sort of pass this one over to, I guess, Adair, you probably would be the best one, talk to us a little bit about where we are with billing and where we're hopefully going.
Yeah, sure. So first I have to say, sort of unequivocally, like I am no billing expert. And also because we're sort of limited on time here, I think this probably could be like an hour plus talk in and of itself.
Sure.
But I'll share some billing resources that sort of specifically relate to hypertension management, since that's the focus of our talk today. So I think we all are fairly familiar with this idea that pharmacists are not yet like recognized as providers under Medicare. And so they can't directly bill for most of the clinical services that we're trained to provide. However, through collaborations with other, clinicians, state insurers, private insurers, health systems, we can start to implement some more sustainable clinical programs. And I think it's worth mentioning that the COVID-19 pandemic has had sort of a really positive impact on this whole like pharmacist provider discussion, when we were all sort of obsessed with like, how do we get medical resources like testing and treatment and vaccinations to more people, especially in medically underserved areas. Pharmacies were sort of identified as ideal locations and pharmacists as ideal deliverers of those care, given our accessibility. And my hope is really that this shift will help push through what has been a very long fight on the federal level. I think the next slide. So the first sort of set of slides that I'll go through here, I have to give like full credit to Target BP for. And if you're not familiar with Target BP, it's a national initiative formed between the American Heart Association and the American Medical Association. And they help healthcare organizations and care teams improve blood pressure control rates using an evidence-based quality improvement program. So Target BP, I understand, was sort of instrumental in pushing through some of these CPT codes for self-measured blood pressure. As Nicole alluded to, this is something that either a clinic-embedded pharmacist or even a pharmacist who's outside your organization in the community space could help assist with. So these codes got pushed through, I think, right around the same time we were all like transitioning to telemedicine during the pandemic. So it was really timely. And they allow healthcare providers to bill not only for training a patient on how to use a validated SMBP device, but also for collecting and formulating a treatment plan based on received SMBP data. So those codes are the first two that are listed there. And this is a slightly off topic, but I just want to quickly call out the validatebp.org website that also appears on this slide. This website is a list of validated validated home, office, and ambulatory blood pressure devices. I know after the pre-work, there was at least one audience member who had submitted a question asking about like whether we recommended a specific model or device. This is the resource for you to go to and find a device that you feel comfortable with. But these codes can really only be billed if a patient is using a device that's validated and on this list. Next slide, I think covers, yes, RPM, great. So remote physiologic monitoring services involve the transmission of patient-collected physiologic data to the healthcare team. And then these data are analyzed to determine what changes need to be made to the regimen, the treatment regimen or treatment plan to improve patient outcomes. And again, while pharmacists may not be able to be recognized as billers through some payers, there are opportunities for pharmacists to collaborate with clinicians to enhance access to RPM services. I know, again, after the pre-work, there was at least one audience member who said they were getting ready to start an RPM program. And I know of another pilot that was done at RX Clinic Pharmacy, I think is what it's called, which is like an independent community pharmacy located in Charlotte, North Carolina. They published on a small pilot they did. So this is, again, a community pharmacy that established a contractual agreement with local supervising community clinicians. And in 2020, I think it was, they rolled out a program which was 100 patients from 4 collaborating clinics. And they asked patients to use either like a Bluetooth or cellular connected SMBP device to measure blood pressure. The pharmacy team received all the readings on those monitors. And if the readings were outside of a defined range of normal, the pharmacy technician prompted the pharmacist to reach out to the patient. And the pharmacist could then reach out to the patient to determine if there was an escalation in therapy needed. And the escalation was, sort of clearly defined by the protocol or the collaborative practice agreement that existed between the community pharmacy and the supervising provider. So again, opportunity abound for collaborating in this respect. On the next slide, I just want to call out that there are sort of stipulations for how these codes can be used. So it's important to sort of read the fine print here and understand the situations and timeframes when codes can and cannot be used. For example, you can't bill for receiving and responding to SMBP readings in the same month as a patient has an ambulatory blood pressure monitor. So it's important to know those distinctions so that you don't get caught out and you can bill for the services that you provide. I'm not going to go over all this, just sort of in the interest of time, and we don't obviously expect you to be able to absorb everything on these slides right now. I think we'll provide the links to the resources at the end of the talk. I do want to move on to the next slide just to talk about one of the primary means of performing billable services, which is through incident to billing. So that's where pharmacists can provide services incident to or in support of a physician. And this can be something like patient education, lifestyle management, or even something like CMM or MTM. In order to bill incident to the physician, Medicare stipulates that 9 requirements must be met. And they're sort of outlined. I know this is a very busy slide, but the patient still first has to be seen by the physician. The physician has to have that sort of referral process where they've authorized this service. And the physician must continue to see the patient at a frequency that sort of reflects that he or she is still actively participating in the treatment of the patient. Some people have interpreted this as sort of like a rule of 3. So like every 3rd visit must be with a physician. It can't be like the patient is only seeing the pharmacist in perpetuity and the physician's not checking in. There are stipulations about where these services can be provided, unlike stuff like RPM that can be done in different settings. This service is usually provided by the pharmacist in the provider's office or a clinic. It's got to be medically appropriate. Of course, it's got to be within the scope of practice as dictated by the given state's Pharmacy Practice Act. And yeah, you can see sort of some of these other things. I think the last point is really important, that the pharmacist must be an employee leased or contracted to the physician who is the supervisor. And the practice must have some legal control over the pharmacist and the services the pharmacists are providing. And it must finally represent an expense to that practice. And expenses can mean a lot of things. It can mean salary, it can mean non-salary support, such as providing the exam room or providing office supplies or even staff support. So that's sort of loosely defined. It doesn't necessarily mean that they have to be a salaried employee of that organization. If we go to the next slide, I just want to highlight there's a lot of sort of misconceptions about incident to billing. So the 99211 code is really the code that we see most frequently used when pharmacists are trying to bill for services. But there are higher levels of billing for pharmacists. Specifically 99213 and 99214 codes represent more intense services, and they can be billed at much higher rates. So the current rates for 99211 is somewhere in like the range of like $20, whereas the higher levels can, be in excess of $110, $120, $130 for each visit. And the Pharmacy Times not too long ago did sort of a break-even analysis. And at the 99211 codes, a pharmacist would need to see 122 patients per week to break even, which is just insane. But at the higher levels, at 99213, 99214, you'd only need to see 25, 26 patients per week, which feels like a much more manageable load. Again, it's sort of in the interest of time, I'm going to wrap up and just say a quick word on the next slide about the California Right Meds Collaborative, or CRMC, because I'm sort of hoping that this is where we're headed as it relates to pharmacist reimbursement. So CRMC was launched in 2019 by Dr. Stephen Chen at the USC School of Pharmacy, and its primary aim was to improve health outcomes in local communities while simultaneously decreasing healthcare costs and reducing unnecessary hospitalizations. The collaboration itself is sort of a consortium of independently owned community pharmacies, health plans, and academic and professional organizations. And they serve over 3 million low-income residents in the Southern California region. CRMC pharmacists and pharmacies deliver what's called high impact comprehensive medication management, and they do so through a sustainable value-based payment model. And I'm going to repeat that. It's a sustainable value-based payment model. So this particular group of pharmacies have sort of banded together and contracted directly with these two health plans, LA Care, which is a Medicaid provider in California, and also the Inland Empire Health Plan, to provide a service, and they're being directly compensated for it. So it's really exciting. In the CRMC model, patients who have not achieved clinical goals of therapy are identified by the health plan, and then they're referred to these participating pharmacies. And once they get there, the pharmacist is, understanding what the patient's medication experience is, what their history is, what their preferences are, their beliefs around medication. They identify what the actual use patterns of all medications are. They assess medications for appropriateness, efficacy, safety, interactions, all of that. And they ultimately develop a care plan that gets communicated back to not only the patient, but the patient's primary care provider. So it really sort of pulls together all the approaches that we talked about. There's like sort of this warm handoff from the payer who has notified the patient that, you're not meeting goals, and we're going to connect you with a pharmacist who's going to help you achieve them. And then the pharmacist is helping develop a care plan that then gets communicated back to both the patient and the clinician. So it's really sort of a full circle of communication and a true team effort.
So thank you so much. It's so amazing to kind of see what's possible, what's being explored out there, sort of the ideal state for all of us. In the interest of time, I think we're going to close out our Q&A session and just say thank you so much, both to you, Adair and Nicole. I wanted to mention we have a lot of really good questions still in the Q&A, and I think what my team is going to do is gather those and do our best to answer those offline and send them out with the slides. So just so you know that we want to make sure that we're addressing the things that are of most interest to you. If we can move on to the next slide, I wanted to just quickly share with you, we do have a lot of resources for you, and you will have these slides very soon. So we have some resources on best practices for heart disease and stroke prevention kind of in general. We have resources on pharmacist prescribing and clinician collaborative practice agreement scenarios. Next slide. We have a resource on using the pharmacist patient care process to manage high blood pressure. We have several resources here on billing for pharmacist services. I know that was of interest. And then we have several great examples of pharmacist-led hypertension management programs. I think these are really important because they help clinicians see that they can really improve the care to their patients and their quality outcomes, including two big ones, the LA Barbershop Blood Pressure Study and the Michigan Medicine and Meyer Pharmacy Hypertension Program. I highly encourage you to peek at those. And then a total non sequitur, not really total non sequitur, but it is related to cardiovascular health. We just wanted to put in a plug for a new campaign that CDC has called Hear Her. And this is focused on preventing pregnancy-related deaths, which are usually often related to hypertension, by sharing messages about urgent warning signs. So with that, I'm going to turn it over to my colleague at the AMA, Rupi Hayer.
All right, great. Thank you, everyone. Hi, my name is Rupi Hayer. I manage the CME process for this learning lab. So here's just a high-level summary of how to get access to your credit. So we'll send these slides with you, but the activity page link is here. Once you click on that link, you'll be directed to either log into your EdHub account. If you do not have one, you'll be directed to create one. And once you're in, you'll be directed to hit the start button, and complete the quiz. After completing the quiz, you'll be asked to select the appropriate amount for CME to claim. And just a reminder, you have until June 28th, so that's about 45 days from now, to claim your credit. Next slide. And then here's just a short set of instructions on how to access and download your certificate of participation. So again, once you've logged into your account and you completed the quiz, you'll see on the top right-hand corner, there's an opportunity to select transcript. And from there, you can find your completed activity and select certificate to download. And next slide. So here, just a friendly reminder that we do have our previous learning labs on demand on the EdHub site. So the treating patients with hypertension, once the RX is up there, the cholesterol one, along with the motivational interviewing one on medication adherence, all three are up on the EdHub site on demand in case you. Last one that we did, the bidirectional text messaging, that will be up shortly. And then finally, this is just a reminder about our next learning lab, which is scheduled for July 19th. And that one will focus on improving blood pressure in African Americans and some common strategies to achieve health equity. So that's scheduled for July 19th from 3 p.m. to 3:45 p.m. Eastern Time. Thank you again all for attending. We appreciate you taking the time to join us today, and hopefully you will join us in our next session in July.
Thanks, everyone.
Thank you.